acknowledge their elders past and present for their part in the continuation of culture and care for country, and for welcoming us on country and sharing their cultural wisdom with us on a daily basis. And I'd also like to acknowledge any First Nations people that we've got with us this afternoon. I'm just going to very briefly introduce our speakers, but I will give them the opportunity to talk a little bit more about what they do. Joining me here is Professor Beverley Vollenhoven. That's very good. He's a reproductive endocrinologist and infertility specialist. She's the head of gynecology at Monash Health, deputy head of obstetrics and gynecology in the... Oh,
it's taken a while to
sorry, okay, thank you. In the Department of Obstetrics and Gynecology at Monash University and a clinician at Monash. Joining us online is Dr. Carmel, Crock, who's an emergency department physician and chair of the Australia and New Zealand affiliate of the Society to Improve Diagnosis in Medicine. Carmel has also received a Medal of the Order of Australia in 2021 for her services to emergency medicine and to medical education. And she's a passionate advocate of diagnostic excellence, shared decision making, clinician wellbeing, and the quality of safety of patient care. And lastly, we have Laura Brandon, who is an experienced Sydney-based art consultant, artist mentor, arts educator, arts writer, and specialist art archivist, having worked in the art industry for over 20 years. As someone who lives with multiple chronic health conditions, Laura is a passionate advocate for people navigating the medical system and the ongoing difficulties they face in day-to-day life. She speaks quite openly about her own experiences with a view to giving insight into those who suffer with chronic illness and as a support for others who face similar challenges. We're very pleased to have a really wonderful and broad panel, and I'm really looking forward to this conversation. But to begin with, can I ask each panel member, maybe we'll start with you, Beverley, if you can, to sort of give us a bit more detail about your role, your professional role, and your experience and engagement with the issues of the kind of issue of dismissal of chronic health, the issue that we're at talking today.
Alright, so I'm a clinician, and so half of my work is seeing patients, and so I see women because I'm a gynecologist and I don't do any obstetrics. And so I have a lot of women who come with chronic gynecological conditions such as endometriosis, pain may not be related to endometriosis, and other gynecological conditions like heavy periods. And so I have a lot of, obviously, interaction. I interact with women every day. In the university, we have a lot of research, and we're looking at research to try and help this. Yeah? So I'm also on the Victorian Women's Health Advisory Council, and that
Inquiry into women's pain.
yeah, so that's part of that remit. But I've been on the other side because I've had breast cancer and then I've had a hysterectomy. Now they were all fairly okay because I kind of knew what was going to happen. But then this year I fell over playing pickleball, don't play pickleball. And I fractured my wrist and I fractured my pelvis in 3 places. And so I haven't done orthopedics since I was an intern, way out of my league. And it was really quite interesting because I was transferred to the Alfred Hospital, because I was a multi-trauma. And it's quite interesting being on the other side of that, and having young interns, male, telling me what to do. It's like, no, I don't want to do that. Actually, why are you making me do this? Yeah, it was quite interesting to see, because I think, as a doctor, you're not used to being questioned about why you're doing something. And I get questioned all the time because of the nature of patients I see. Orthopedics is very different. It's doing something, right? You're doing something, you're doing something, you're doing something. And when someone's actually questioned, they go into this sort of, you can actually visit this even recoil, about, well, why are you saying it? So for example, they wanted to take blood from me after I had my surgery. I had surgery and I had no veins, and they were going to take blood from my foot. And I said to the person, stop right there, you're not taking blood from my foot. And then just ask, why do you need to take blood? And there was no explanation, it was routine blood. I said, well, what's routine blood? Mind you, this was a Monash University medical student, and I'm in charge of the department. So I'm very ashamed about that, really ashamed. Yeah, it was like, what are routine bloods? Tell me what they are. I don't know what they are. Why do I need to have them?
We'll get back to this, but I think it's a really interesting, because your perspective of being in the profession, and you can ask those questions, but I'm presuming that as a patient who would not have that experience,
and that's what I'm saying.
You would just be like, whatever.
Yeah, exactly. And I remember, sorry, I'm cutting you over. I remember being in a ward with another patient who was a burns patient, because I was in the burns unit, and no kidding, the plastic surgeons came to see her at 6 in the morning and woke me up, woke her up, never introduced, because I was awake, I could hear it, never introduced themselves, talked to her like she wasn't there, and then left. And I said to the nurse, they were so rude. I can't believe people talk like that.
You've made notes for when you got back to the uni, I presume.
Yes.
Yes.
Amazing, actually. Yeah. Anyway, sorry.
That's okay. Carmel, can I throw to you to tell us a bit more about your professional role and your engagement and experience with this issue as an introduction?
Sure, Vince. So just briefly, and I'll segue hopefully from Bev a little bit. I'm an emergency physician and I'm director of an ED. And I guess my passion around diagnosis comes from working in ED where everything is really unsure and rapid paced and you've never met a patient before. But to follow from what Bev said, my dad was an orthopaedic surgeon and he loved art, so I'm just going to move my head to the side. So this is a painting behind me you can see that was in my bedroom when I was a kid, done by Dennis Spiteri, who's a Australian Maltese artist. And a lot of Dad's patients were artists and he would become friends with them. But Dad taught me to listen really carefully and to observe carefully, and used to take us to exhibition openings at Powell Street Gallery as kids the whole time. So it was just an important part of my childhood. So I think Vince and I were chatting about this before, and I'm happy to talk a little bit more about the diagnostic error stuff, but I think to put it within the human context, medicine is these human connections, and my probably greatest mentor was my dad, who was a surgeon. So Bev, yes, I agree with you, sometimes surgeons have terrible communication and sometimes they're beautiful mentors.
And Laura, can I come to you and if you can tell us your kind of experience and how you fit into this conversation?
I can try. I'm clearly not qualified in any field. In terms of my work, I've worked in the arts for 20 years. Over 20 years, started as a high school teacher of art and design, then moved into galleries and other areas that have been touched on before, and obviously art and design is my passion. And then I also happen to be someone who's lived with chronic illness, multiple chronic illnesses. They call them comorbid conditions, so multiple ones that feed into each other. And I've lived with multiple illnesses since I was about 15. And I'm now at the ripe old age of 42. And the way I fit in, or why Michelle reached out and asked me to speak, is I've dealt with so many experiences that some people don't have, that they don't believe unless I show them evidence of it, or just think, okay, how are you even still here? And over time, it's become a passion of mine to talk about it openly and not be afraid to tell people what I've been through, not only to help me, but to help other people understand and just to be acknowledged that these things do happen to people, shit happens, and you have to deal with it. Sometimes it's straightforward in dealing with it, but most of the time, especially with chronic illness, it's not straightforward and there's no one answer. And any experiences I talk about are my own. And every single person here, if they've had an experience with medical illness or a family member, a friend, every single person has a different experience. And it's just acknowledging them and how their life works in dealing with those and living with those illnesses.
Thank you. So I want to, I suppose, start at the top, which is around the sort of the medical questions or the sort of medical framework. Carmel, you're the current chair of the Australia and New Zealand affiliate of the Society to Improve Diagnosis in Medicine. To me, that such an organisation exists suggests that there's an acknowledgement that there needs to be work done around clinical diagnosis of patients. So I'm wondering if you could tell us a little bit about that organisation, its role, and what drove for it to be established.
So, Vince, there was this report that came out in 1999, which was thought to be like the beginning of the whole patient safety movement, and it was called To Err is Human. And that report was about how we can improve, reduce errors in medicine and how we can do better for patients. And there was a group in the States that read that report and noticed that diagnostic errors, like how we diagnose patients, how we speak to patients, was completely left out of the patient safety movement, that it was actually invisible. So surgical errors, you can kind of see them and you hear about them. Medication errors you see and hear about. But when it comes to diagnosis, it was this sort of hidden thing. It's like they have this diagram of an iceberg with the surgical errors and medication errors at the top, and diagnostic errors are invisible. And often, I think, you know what Laura was saying, patients may have symptoms, but you can't see anything. So this group wanted to make diagnostic errors visible. Bob Wachter was at the first conference in 2008, so it was about 10 years after To Err is Human, and he said, why don't diagnostic errors get any respect? And this group is a really interesting group because it's not, most conferences, medical conferences, you go to are doctors. This is doctors, patients, relatives of patients who've lost, you know, like children to diagnostic error, sociologists, anthropologists, linguists, psychologists. So it's really interdisciplinary, and it's a group looking at how can we improve diagnosis? You know, how can we break down this notion that it's something that's in the doctor's head that they do, and the patient receives something for the doctor, receives a diagnosis. How do we look at diagnosis not just as a label that we whack on a person, but as a process, a team effort between patients, doctors, family members. And, you know, one of the very first conferences I went to, this father went who'd lost his son, Rory Staunton, who was a 12-year-old boy, to sepsis. So the little boy had some vomiting, saw a paediatrician, went to ED, was sent home and died of sepsis. So this group sort of says, hang on a sec, there's certain diagnoses which are really difficult, which can happen rapidly. There's other diagnoses which are protracted and invisible. But can we look at maybe what's the rate of diagnostic error in medicine, and how do we improve, you know, reduce the rate of diagnostic error? So our group looked at it and do a lot of research around this, and are very open about talking about diagnostic error. Some people don't like us to use the term error, and I get that, but on the other hand, the subject matter is so important. But, you know, looking at this and trying to see diagnosis as communication, as relationship between patient, doctor, you know, we're all in this together. I don't know if that's an adequate summary, Vince, to start off with.
Yeah, no, that's great, thank you. I mean, you did touch on something that in preparing for this, I was very mindful of, and that is the kind of words we use, and the word error seems to me, having had family experience of people who have been misdiagnosed, including someone who was sent home and ended up dying of a brain aneurysm overnight and was told he just had a headache. That the use of the word error, for instance, seems to, as you said, seems to be a no-go. But I think the other thing that really interests me about this group is, I presume what you're not trying to get to, there needs to be an acknowledgement that there will be errors. And I suppose, is there a benchmark where, you know, where you say, okay, well, you know, we need to improve, because obviously we've identified an issue, but like how far can that improvement go?
So that's a good question. Usually it's said that the diagnostic error rate in medicine is about 10 or 15%. What this group does is tries to identify recurrent diagnostic pitfalls, like which things happen time and time again, like patients with sepsis being sent home, or women with pelvic pain being not listened to. You know, where are your recurrent diagnostic pitfalls, and how do you address those? So, for example, for heart attacks, you know, the diagnostic error rate, we've done pretty well, and that's about 2%. For other things like dizziness, it might be 30, 40 or 50%. So this is an under-researched area of medicine, like I say, because it's hard to count them, and it's hard to say, oh, was it really an error or wasn't it?
Yeah.
Because of this question, our conference is called the Diagnostic Error in Medicine Conference, but the society is called the Society to Improve Diagnosis in Medicine, because we didn't want to get too caught up in wasn't this particular case an error? Because error sort of then leads a little bit to blame often.
Yeah.
So, you know, I mean, I've had people say to me, you know, you can't use the word error, you can't talk about diagnostic error. We have to, we kind of have to, you know.
Thank you. I want to segue to Beverley. Part of your work is, and you mentioned you work as an academic and a supervisor of postgraduate students. I'm wondering if you can comment on whether you see a correlation between the current training received and the kind of position that we've found ourselves in the context of what we're talking about today around sort of, you know, misdiagnosis, or better diagnosis and better treatment of people with chronic health. Do you see a correlation between the kind of training that's been given and improvements in that training?
So I think, so just one thing that's made it better is that we have more diagnostic options, okay, than we had before. So for example, I'm 63, I'm old. When I was a medical student, we didn't have MRI, okay? We only just had CAT scan. We didn't have the internet actually. So we had to go to a library. So there's more diagnostic tools. What we don't want to do though is to go to a diagnostic tool without actually talking to the patient. And that sometimes happens. So, you know, because in my work, a lot of just actually talking to the patient, taking history, will give you an answer as to what's going on. You don't need these sophisticated, you know, tools. MRI is expensive as well, right? So you don't want that you don't want the advanced diagnostic techniques to get in the way of actually taking history and doing an examination on someone.
Yeah.
Okay? Because that's actually really important. It's really important to actually talk to someone and ask them what's wrong with them and how it affects their life, and, you know, and acknowledge them. Then sort of say, oh well, let's just go and do an ultrasound, okay? Or because that's what we do a lot. We do lots of ultrasounds in gynecology. But it is actually important to just find out what's going on, how it affects their lives, and then talk about, okay, well, you know, these may be the things we need to do to try and find out, and then, you know, manage the problem.
Yeah. And as far as sort of how you train that with students,
Well, that's part of their medical training. Now, I think when I was a medical student in my era, we didn't have these diagnostic tools, so we had the history of examination, right? Now, there's all these diagnostic tools, and I think we have to try to instill in students that it's actually really important to take a history, ask the patient, talk to the patient, and not do the text. So, for example, I'll go back to my fall, it's still fresh in my mind. It was only 5 months ago. I don't know how many days, but 5 months. Anyway, I went to Rosebud Hospital, and the Alfred wouldn't accept me till I had a whole body CT. It's like I kept saying I didn't hurt my brain, I didn't hurt my neck, I didn't hurt my back, but they wouldn't accept me in the hospital until I'd had the whole body CT. So like now, why? You know, there's money gone. You know, there's Medicare, right? And I already cost Medicare a fortune by just doing that, without actually any need to do it.
Yeah.
But then when I got there, they insisted on feeling my back. And I said to them, I cannot roll. I've got so much pain. You've done a CT. Why do you keep wanting to examine my back? And as the 5th person came, I said, look, you're going to have to give me fentanyl if you're going to feel my back. They gave me fentanyl. It's like, why are you doing this? You know? And it's like, just ask the patient. I know what I have. It was witnessed.
Yeah.
You know? So, but anyway.
Laura, can I
go on?
Bring you in? And you mentioned you've lived with chronic health issues for a long period of time. But I want to, and it obviously impacts every aspect of your life, I would assume. But I want to focus on work in particular. And I'm just wondering if you can speak to us about your experience in the workplace as someone who's had to deal with chronic health. When we were talking yesterday, you talked about, you know, the idea of the kind of stigma that's attached to someone in a workplace that's got chronic health. It's like, oh, they're not at work again, and those sorts of things. And also this idea that if you do have chronic health concerns, that somehow you shouldn't have a career. So I'm just wondering, I know it's a sort of big question, but I'm just wondering if you could speak about your own experience within that kind of workplace environment.
Yeah, I guess the first thing I would say is a lot of chronic health or a lot of health issues are relatively invisible. So if someone looks at me, they're like, you look fine. And today I'm doing pretty well. Like I managed to get myself here. I'm here in one piece. You know, doing pretty well. But when you show up at work, whether it's at an office or teaching at a school or at an art gallery or wherever it is, unless you can physically see something wrong with someone, oh look, she's broken her arm or she's on a walking frame or whatever it is, there's an assumption that you're fine. And I don't mind saying some of my chronic health illnesses. I have Crohn's disease. I have, what else have I got? POTS, which is postural orthostatic tachycardia syndrome. I have arthritis. I have celiac disease, which is just a bonus round. I have, what's the other one now? I've had so many things happen to me over time. And a lot of those things were very visible. Sorry, I'm sort of losing my way. In terms of working, I would show up to work, and people would say, you look great, you look fine, and I'm busy struggling to get through the day because I feel like crap. But I've probably taken all of the meds that I need to take to kind of get through the day. And then I had a condition, it's a definite bonus round that no one wants to achieve, which is called pyoderma gangrenosum. It's got nothing to do with gangrene, but it's where the autoimmune system attacks part of your skin, and basically it starts to kill it from the inside out. So this was in 2018, 2019, I was a week away from having my legs amputated from here down. I was working from home, and the person I worked for at the time, who knew I had chronic health issues, and they had put up with it for a long time and been relatively supportive, didn't believe that what I was saying was actually relatively true. So I was called in for a meeting to talk about my work situation, and I couldn't walk. And when I could walk, it was with a walking frame. So my mother drove me in to have a meeting with my boss and the lawyer at the time. And I walked in, and the receptionist looked at me and she goes, Laura, what the hell? And I'm like, yeah, I have been saying I was sick. And then the lawyer just looked at me and was almost like, okay, you can't go down this path. But my boss at the time was just like, now, okay, clearly, yeah, there's seriously something wrong with you. I'm like, yeah. And this is not placing blame, this is just what happened. She's like, oh, clearly you're sick, we're really feeling bad about it, so sorry. But we're going to cut you from permanent part-time to casual. So sorry, this is your paperwork, you've got no option, here you go, out the door. I was too sick at the time to even have the conversation. I was literally on 16 medications, you name it, I was on it, like, barely functioning, couldn't drive, every opioid under the sun, steroids, my boss said to me, Laura, you look like a balloon. So really nice to have someone, when you show up at work, you just look terrible. How are you? Terrible. So that was one experience. Like I got my job taken away, and at the same time I lost all my long service leave. I had to just give it away because I was too sick. Anyway, that's one of the negative experiences, but on the flip side I've had a lot of positive experiences, and one of the ways that I've dealt with living with chronic illness is I don't work. I started my own art consultancy in 2019, but I also work with a fabulous team in Melbourne, and my lovely boss Alana is here today supporting me, and I really appreciate it. And I work with a team in Sydney as an arts writer, and I like to think that the people that I work with, I choose to work with them because they understand me, not me, but they have compassion for what other people are going through. They don't need to know every single detail of what I'm doing, or, but just that person has a life outside work. You need to get this job done, that's great. And we need to get it done by this deadline. Can you achieve this deadline? Yes. But it doesn't matter if you do it from home, or if you do it from the office, or if you need to go to an appointment. Just an awareness that people have stuff happening outside of work. When I moved away from working with the person that I did for so long, who really fundamentally damaged me mentally, and took me quite a while to get over, I proactively work with people that support each other as humans. So I work with artists as an artist mentor, and I invest in them as a person as much as their practice. Well, I feel like I do.
Yeah.
Because a person is a person, not just the sum of their body parts. And it's also, as much as it is their physical, it's mental.
Yeah. And I think it's sort of one of the things you touched on is just the kind of work attitudes of, that we need to progress around things like, and I suppose this is one of the outcomes of the pandemic, this idea of a level of increased trust that people can work at problems and do their things. But the thing that you touched on, we were talking about yesterday, this idea that outside of work, people have got lives as well, and the idea that the workplace doesn't need to know everything, but just has a level of trust and acknowledges that, hey, sometimes there's other things going on and we just have to navigate that as well. And I think that's more of a kind of a workplace relations attitude that we need to change.
The one thing I add, if you don't mind, is that I've given a number of talks at medical conferences and nurses conferences and patient conferences and been like not a guinea pig as in treatment, but for medical students coming through because they've never seen this condition, pyoderma gangrenosum, and it's now in books if you want to look up my legs. They're famous. And that this is the first time I've talked to people that aren't in the medical field. So, which I find quite significant to actually have. So I had my mum a couple of weeks ago said to me, "Can you explain?" She actually sent me a message. "Can you give me an elevator pitch on how medical, the medical chronic illness that you deal with, how does that relate to art?" I can't put those two things together. And my answer was like, "Why are you doing more work?" But my answer was like, okay, if a writer is asked to write about these experiences, chronic health or illness or whatever it is, no one questions why they're writing about that or why is that their subject and why is that important. And so I said to my mum, apply that to an artist. Like that's their way of processing that issue. And yeah, it's when people say art should be accessible for all, and yeah, that's something that I believe. I'm a believer. I guess it was a way of me explaining to my mum, who's not involved in the arts at all, that's why this exhibition is important, because no one's questioning a writer about that, why they are writing about that. No one's ever asked me to speak about my issues in an art context, but the opportunity to do so is a privilege.
Yeah. Thank you. Yeah. And we will, I will say we will get to the art as we work through the conversation, but I think that's a really important.
This is trauma counselling.
I want to, Michelle's exhibition, and we've talked about this, is not necessarily about gender. The call out, so the works that you see, for those who are not familiar with the works, Michelle did an international call out for people who had chronic health issues dismissed, and what you see is a collection of responses, letters, doctor's reports, and it was never intended to be gendered, I think would be fair to say. But I think it's, we can't escape the fact that the issue is gendered, and I think that really comes to the fore when we, with the Victorian Government announcing earlier this year the inquiry into women's pain. And I just want to read something that is on their website, and it states, medical gender bias routinely leads to a denial of pain and therefore lack of pain relief and associated treatment for women. And then Jen Kearney, the Federal Assistant Health Minister, told Ali Moore on an ABC Radio Melbourne program earlier this year that women are still battling to access care in a health system designed by men for men. And so this issue is gendered. I don't think we can sort of get away from that. So perhaps if I could go to you first, Beverley, because you are on the working group.
Yes.
Yeah.
Not the pain one.
Yeah.
Yeah.
So the issue of the dismissal and denial of pain is, as I said, is very gendered, in that it mainly affects women. Can I ask, beginning with you, why you think this is the case, and what are the steps that are currently being taken in the work you're doing and the Victorian Government to kind of try and rectify this?
So if you look at hysteria and hysterectomy, they're the same root, right?
Yeah.
So, and that's, going back many years. And so women have been thought of in the past as being hysterical, okay? And that's the way it's evolved, right? Right, that's the way it has evolved. And that's looking at it from a male point of view. So, that's why women are dismissed, because like you, they may not go in on crutches or, you know, but they have pain because they're living with Crohn's disease or endometriosis or whatever, but you don't see it, okay? Because you don't, you know, going in with, you know, open with, you know, tummy open, so you don't see it, and therefore you must be making it up, okay? Unless you walk in like that, you know, if you walk in like anyone would walk in, well, you know, you must be okay because you walked in and you work and you do this. But I think forget that there is, you know, there's taken work to get there, you know, in terms of whatever you've done, like you've taken pain relief or, you know, you've gone out and done, you know, some physio or whatever, there's been work to get there. But that's not acknowledged because it's not seen. Yeah. And so I think that's why women's pain, or there's no acknowledgement of their pain, maybe. Yeah. And that's why it's probably a little bit more dismissed because it's not obvious. Yeah. Yeah.
Carmel, can I get you to comment also on that, on this sort of gendered nature, and why you think that's the case, and also the kind of things that are happening to rectify that, and things that we potentially can do better?
Yeah, so within the diagnostic error group, it's sort of been noted that women, for example, are less likely to be diagnosed with a heart attack if they have chest pain or arm pain. So the group is doing quite a bit of work around women and misdiagnosis, but I wanted to sort of bring it back to also my ED perspective, and I'd be interested what Laura has to say about this, but often patients with chronic conditions, and often this will be women with chronic conditions who come to an ED, are either not believed or not listened to, partly because of what Laura says. You look fine, so, you know, what have you come to ED for today? And I have a really good friend with Addison's disease who was an opera singer, and, you know, it's a deadly disease if not diagnosed. She took about 2 years to get a diagnosis and saw 12 doctors, so prolonged sort of misdiagnosis, but she'll often go to ED and tell the triage nurse, I've got Addison's disease, I'm in a crisis, I need steroids like right now, and there'll be, even though the patient has all this information, female patients can be dismissed as if you're not the expert on your own health condition, which I find really interesting. And she describes when she's been to ED and she goes, you know, I'm having an Addisonian crisis. Nobody will believe her, and then she'll say, please take my blood pressure, and her blood pressure will be like 50, and then the nurse says to her, oh shit, you know, and sort of believes once there's some piece of evidence. So, yeah, this idea of why women are misbelieved, I'm not sure why, is my real answer, but some of it is historic. Interestingly, there's a quote by William Osler, who's a very famous Canadian physician, like the father of diagnosis, and he says, listen to your patient. He is telling you the diagnosis, but he says he, not she.
Yeah.
So maybe it's in the history of medicine.
Yeah. Laura, can I bring you in here about something you mentioned to me yesterday, and you said that navigating the medical system is almost like a full-time job. And I presume, hearing from Carmel and Beverley about the fact that we don't know why, but it is obvious that women get dismissed and not listened to. Can you talk a little bit about what you mean by the kind of, you know, having it's almost another job to navigate, and what your experience of that has been, and how the gender element actually has impacted that?
Yeah, to be completely honest, I didn't approach this talk in terms of the gendered nuance of it. Whether you're male, female, or other, I can only go by my experiences. So I give a couple of examples of things that have happened to me. And I've got a team of doctors. Like every condition I have has a different doctor I've got to see. Some of them are male doctors, some are female doctors. but they're all really great doctors. So in terms of the treatment that I've received, my spinal surgeon has the worst bedside manner of any doctor I've ever come across, but he's incredibly good at what he does. I'm like, okay, just do what you need to do. Let's not chat, because that's not the final point. Yeah, so I had 7 ruptured discs removed from my spine, my lower back, and my sciatic nerve untangled from my spine in 2022. And he came in and said, okay, next day, up you get, we're going to get you walking around. I'm like, yeah, I'm not quite up to that yet. He's like, no, everyone's good at it. And I said, no, not. I walked out, and I'll come back to that one because that was another one I was going to do. Oh, when I had the issue with my legs, my dad drove me. I have a husband, and my husband is very helpful, but when I got sick, my daughter was about 3. So it was like Andrew was going to be around for Isla, our daughter, and what I needed, my parents would help me with. So that was kind of how we decided to split it, which is to make things as normal for her as possible. So Dad was always going to be around. So with my legs, they kept saying, just go to ED. And I was sent to Westmead Hospital in Sydney, which is quite far from where I live, but apparently they had the best doctors for what I was experiencing. And I have documents saying that I was drug seeking, that I was there just to ask for opioids. I never asked for an opioid, ever. It was not as bad as I thought, and one way that they tried to treat the condition was like, okay, we don't want to give you too many opioids. Then they ended up giving me like 7. I was like the buffet of opioids, which was fun for a while, but it's not good for a long time. But one thing they did to me was, so I had massive wounds on my legs, and they're like, okay, we think that you need steroid injections into your legs. I'm like, I don't think that's going to help. But I'm like, you're the doctors, okay? And they had no idea. So every week I would go in and they would put 20 steroid injections into one leg and the other leg with no anaesthetic whatsoever, and I would just white knuckle it. My dad would sit and watch, and I would just white knuckle it, and it didn't help at all. And I said to them after a time, this is not going to work. I know this is not going to work. And they're like, we're the doctors, I'm like, no, you've got to stop. This is not going to work. And one thing led to another, and I had different treatment. And I was finally approved for a biologic agent for Crohn's, which also treats PG, which was the thing with my legs, which started turning it around. But had it not started turning around, I'd be an amputee. That's one example. Another example is going back to gynecological issues. I had in 2021, I was having issues with my gut. Went to my gastroenterologist. Sorry, this is long-winded, guys, cut me off. I said to him, there's something going on. He's like, it's just your Crohn's again, we'll just up the steroids, we'll do this, we'll do that. I'm like, nah, it's not my Crohn's. I know, I've lived with Crohn's for 20 years. I know it's not my Crohn's. Yes, it's your Crohn's. He sent me this person, that person, that person. I eventually just rang the doctor and said, you know me so well, I'm not making this up. Like I've been told a lot of times, you're delulu, making this stuff up, hysteria. And they said, okay, we'll do a test, CT test that they very rarely use. It's really expensive, you won't get any rebate. I was like, whatever. That was on a Monday. On the Tuesday, I got a call from the doctor saying, we need to get you into a gynecological oncologist. On Wednesday, I was in his office. They found a 25 centimetre tumour in my abdomen, and several tumours in my left fallopian tube and left ovary. I didn't go in thinking there was anything wrong with my reproductive system. I'd never had any issues with my reproductive system. 5 days after that, I was having, I was cut from here all the way down, and they removed like this massive head-sized lump that you could not see from the outside, and my left fallopian tube, my left ovary, and some of my uterus. And I woke up not knowing, because I'd given them permission to take anything that they needed to take out. I woke up going, what did you take? It's like, what's still there? And so they told me, you know, you're fine. But it was me listening to myself, knowing it wasn't the Crohn's. They would have just kept giving me the whack-a-mole, just more steroids, more opioids. If they had left that tumour in my stomach, I would be dead. And that was not me making a fuss over nothing. I'm really not, please look at me. I really want to go to the doctor. This is fun. This is an enjoyable part of my day. I was sick. I just knew what they were telling me was not the answer.
Yeah.
So I had to kind of push for the answer. And that's, I guess, where female, or, you know, being a woman comes into it, because it's like, oh, here she goes again. Oh, what's she going on about again? But it usually ends up going, whoa, they like me. We're really sorry. Completely missed out.
Yeah. I think there's something also in that unfortunately it's because of your long engagement with hospitals that gives you the confidence to say, no, this is not right.
And that's why I speak about patient advocacy, because at the end of the day, you live in your body, you live in your head. If you know something is not right and you are not getting the right answers, don't just sit around and be like, okay, cool, that, you know, I'll just keep taking this thing, or I'll just keep having this procedure done, or they send me for a test and you think it's wrong. Question them, not in a like being in a nagging way, but just like, no, it's your right to ask why they're doing things and to say, I don't think I need that. I was overdosed on gabapentin, which is an opioid, when I was after I had spinal surgery. And I was literally bedbound. I'd had spinal surgery, could not get out of bed, was hooked up to everything, and the doctor came in and titrated the painkiller that was going into my arm, and I had told them before surgery, gabapentin is not for me, you know, it's not going to be the right thing. It's like, I've got no idea what you're talking about. My husband was in the room, and I said to him, something is happening, don't know what it is, but do me a favour and call my mum. My mum's like the most organised person in the world, because Andrew was like, I keep looking up that quote that says, man up and soldier on. Andrew often says to me, eat a teaspoon of cement, like just get on with it, like you're made of tougher stuff. I don't know, something is happening, something weird's going on, and he's like, it's fine, just call my mum, do me a favour. Within half an hour, I was in a stroke condition for almost 8 hours. I could hear everything that was going on. I could hear what the doctors were saying. My mum was filming it. Her mum's like me, she likes to document things, because I knew people would say, no, that didn't happen. I was trying to tell them to get the thing out of my arm, and there's footage of me, it looks like I'm from the Hillsong Church, like I'm like waving my arms around, just trying to tell them to pull the thing out of my arm. And my pain doctor eventually came in, and as soon as he saw I was on gabapentin, he's like, get that thing out of her arm. As soon as they took it out, back to normal. I had told them, please don't give it to me. But the doctor was so like adamant that's what I needed. He like doubled down on it, and he was like, we're gonna give it to you. And I'm like, thanks for that, that was a ride. Whoa, like, yeah, it's just, just like, no, like that wasn't a mistake. That was a serious.
That was just not listening.
Like that, but they could have killed me.
Yeah.
I wasn't planning to sue them or anything like that, but it's like that was a serious
Yeah.
stuff up.
Yeah.
No, let's not put anyone else through that if we can avoid it.
Yeah. I want to touch on something you said, and it's around. You mentioned you had a treatment that wasn't on the PBS, and the context I want to refer to a statement from. I presume this is one of your colleagues, Professor Danielle Mazza, who said a lot of women are still facing major affordability issues, and a lot of products that women use, particularly contraceptive products and menopause products, are not PBS listed. In terms of maternity services, there's a rapid discharge home after delivery because of the need for beds or workforce issues in hospitals. So women are facing major changes like breastfeeding or recovery from caesarean section at home. So reading that, what it suggests to me is that this is not so much just a kind of a training medical issue, but it's also a policy issue. And I'm wondering if Beverley, Carmel, if I can get whether you can comment on the kind of policy issue, the things like not having drugs on the PBS that impact 50% of our community.
Yeah, so actually I'm on a TGA committee as well, so I helped to approve some gynecological drugs. But so Australia is a very small market, okay, for big pharma, and so if we get something at all, it comes late, it comes at a cost, because we're too small for them to service, I guess, one of the better word. And so that's why, newer contraceptive agents are quite expensive. I'm talking about oral contraceptive agents, are quite expensive. In the menopause field, you can hardly get any menopausal drugs at the moment. I don't know if any of you are using those drugs, but there's a patch which is, has not been available. Well, patches have, come in and out of availability. It's been going on for at least a year, and one company's completely stopped making a certain patch. So because there wasn't an ingredient, so I guess someone spat the gummy and said, "I'm not making it anymore." Yeah. Anyway, it's very hard to get those. It's very hard for women because you're feeling like rubbish if you're menopausal, and you can't afford the cost of medication, and you don't have access to medication that's newer and is better. You have access to older medication which is not as good, okay, not as good long term. So there's a huge inequality there. In terms of what was the other part of the question? Oh, breastfeeding and that. Yeah, and going home early. That's a government issue.
Yeah.
Yeah. I mean, the health system is in a crisis. I don't know what it's like in New South Wales, but it's in a crisis in Victoria. And it's been in a crisis in Victoria for over 20 years, and it was the pandemic that showed it, and nothing's changed. It's gotten worse. And we're in a major crisis.
Yeah. Carmel, I'll bring you in here also, but maybe if I can get Beverley also to comment afterwards. But as people who work in the medical profession, who have to deal with a system that is in a crisis, I can only assume that's really frustrating, but these are policy issues. The fact that, as I said, certain drugs that are not on the PBS affect 50% of the community. So, can you speak to potentially like how do these things change, but also, I suppose, a level of frustration of working in a system that is, if I can use the word, broken?
So, look, I'll be really honest, I can't talk much about the PBS drugs and funding because it's just not what I know about. Yeah. But I can talk about a system in crisis and healthcare in crisis. That I'm the living expert. So look, these are my thoughts on it. Hospitals are in absolute crisis at the moment, and it's probably important for patients to know that. but it's really important how we as clinicians treat our fellow clinicians, because that will determine how we treat our patients. So even though we're in crisis, we have got to look after each other, our doctors, our nurses, our clerks at the front desk, because look, we know that sort of society's in crisis, that building companies are going broke and that everybody's got financial stress. So I think we need to kind of take a deep breath and go back to the compassion that Laura was talking about, and, you know, take it day to day. From my perspective, when I'm at work, you know, the patient that's in front of me, the clinician that's in front of me, are my staff okay? You know, are they in crisis? I'm sorry if that's off topic, Vince, but...
No, that's okay. No. Yeah.
Yeah.
Laura, can I ask you, you're obviously New South Wales from Sydney, and we're not quite sure whether there's a parallel there, but do you feel that policy and funding, etc., makes it more difficult for when you engage with the sector?
Definitely. There's a few reasons. Firstly, not all chronic illness, some chronic illness is effectively treated medically, like with medication or intervention. Some can be treated with Eastern medicine or other alternative therapies, not as a you know, hippy dippy, that this, I'm not going to have traditional medicine, I'm going to go down this route. But the Eastern medicine therapies can help, and do, for me, they definitely do help. If they were more readily funded or, you know, a rebate provided, that would take a lot of pressure off, you know, the traditional medical approach, and also the need to rely on medication. I have to take certain medications, but I choose not to take other medications because I don't want to be reliant on those. And Eastern medicine, like acupuncture, like meditation, like Reiki, all of that sort of stuff, those things actually have helped me hugely, and help in management as well, not just when I'm in crisis to get better, but in daily management. The other thing I would say is, in terms of treating a patient, whether it's, you know, intervention or medication, I always go back to treating their body and treating their mind. You can't just treat a body without treating a mind. The mind-body connection is proven. When I had the issue with my legs, I had to wait 4 months to get approved for the biologic agent that I now take weekly, and I will be on for the rest of my life. Initially, to get access to it, it's $1,200 per needle. So I have 1 needle per week. And my family was just like, well, that's just going to have to be how it is. But I eventually got government permission, like, yes, okay, you are bad enough that we can sign it off. So they then started giving me fortnightly access to, it's called Humira, fortnightly access to Humira, and then they were like, you're actually way worse than we thought. So I get compassionate Humira, which means that I pay every 2 weeks, I pay $30 a month, so fortnightly, and the other 2, the government gives it to me out of their compassion. Like, honestly, it's called compassionate Humira. Your compassionate Humira will arrive. It's like, far out. Otherwise, if I didn't have access to it, I would still be on all the steroids. I wouldn't be functioning.
Yeah.
That 1 needle a week at the moment keeps my Crohn's under control, keeps other things under control. On the way flying down here from Sydney, I laughed because, you know, when you get random drug tests, I was like, damn it, they picked me. And I was like, can you open your bag? And she just sort of sort of looked at me and said, have you got a form that says you can have all this stuff? And I, yes. And I like opened it up, she's like, whoa, okay, you're right, just keep going. It's not like I'm going to take it all, but I have to travel with all this stuff because it's, yeah.
We could keep talking for a long time, but we're at 1 o'clock. But I just want to come back as the last question back to the artwork. One of the really amazing things about this show has been talking to people when they're in the space, and almost everyone has some experience with what we're talking about. And Michelle and I have had long conversations about my experience and your experience. But it's a really powerful body of work because it does resonate so broadly. So I'd like to finish by asking everyone how you see visual arts practice or arts practice more broadly, how you see it not only furthering conversation, but also whether you see any, particularly for Beverley and Carmel, whether kind of what benefit these kinds of projects or art more broadly can actually have within your professions. And then obviously, Laura, I'll come to you at last because you obviously work in the sector. But Beverley, can I maybe, particularly as someone who works in university as well?
Yeah, I think it's really powerful actually. Just looking, I'm not really au fait with art, I'll start off by saying that. But just looking at what Michelle's done is amazing. Just reading, I would never caught a blank through, but just reading that screen was just amazing, and just seeing, all the images. I think it's really powerful. I think it's a really good thing for our medical students actually, to cater to them because they're the ones we're training at the moment, and they're the ones who need to see how important this is.
And Carmel, can I get you to comment also on that kind of relationship between, the art world and the medical world?
Look, I think this sort of exhibition that Michelle has done is brilliant, and there should be more of it incorporated into medicine. So, like I mentioned to you, Vince, before this panel, at our Diagnostic Error Conference, we took all the speakers and all the attendees to the National Gallery of Victoria, and we had two of the workers there take us around a Rothko painting and another older painting. And all these diagnostic error gurus from all around the world their minds were blown to see, the power of observation within art and how that could add to medicine. So, Michelle's work to me is a lot about not being listened to, not being believed, not being seen. And I think these connections between medicine and the humanities are really, really crucial.
Can I just say one last thing? Sorry. How many times have you seen a pregnant woman in a portrait or in a painting? Very rarely. Fundamental to life, right?
There are a few current, more contemporary artists who we definitely do, but yes, it's more contemporary.
And Laura,
can I say one other thing about observation? So it's amazing in medicine, how much of medicine is observation and how much we absolutely don't see, so that we need our eyes opened by other people. So I work at a hospital where there's a lot of surgery done on eyes. I had to take my mum to another hospital for cataract surgery, and she was 92, and it was literally the first time I actually saw a cataract patient what they looked like, because suddenly it was my mum. So it's like different things can change our perspective. And I'm like, have I been blind for 20 years? I haven't seen this thing until it's my own mother. So Michelle, I think your work is really, really important.
And Laura, as someone who works in the arts, obviously you mentioned earlier that that you'll view that importance of the arts, but can you comment at all that relationship about how art can function within a kind of medical sphere?
Yeah, I have two, they're possibly more anecdotal. comments. Art, whether you have it at home, whether you're looking at it in a public space, art can bring people joy. It can make you feel emotions. It can, you can connect with it. And, there's a couple of artists in the room that I know and whose work brings me joy when I look at it. And fundamentally, if something brings you joy, how can that be bad for you? And on the flip side, art can also make you feel sheer sadness, and that depending on the narrative of the artwork. But so art has a huge power in how we interact with the world, or just how what we surround ourselves with. Like at home, I surround myself with art that has colour, because that's just what brings me joy. Like that's what I enjoy. The other thing, and it's a way that I've learned to. Well, it's just a work that I've been doing since 2016, 2017. It's this fantastic publication that some publisher will pick me up for one day, and it's my bad art found in bad art found in doctors' waiting rooms, coffee tables. So I have been to so many doctors, so many hospitals, and to pass the time, me and my dad, I was like, I think of that artwork that we've got, it's awful. So I started taking photos, and I put it on my Instagram. I'm like, bad art, and I'm not shaming anyone. Sometimes I'd say, can anyone guess the artist? Or I'd be like, I'm in hospital, and there's this decrepit, the most depressing artwork on the wall. And people started writing to me and saying, I was in this doctor's room and this is what I saw. And I've been keeping these things like 2017. People send them their pictures to me now. I swear it's going to be a book one day. I don't need to make money from it. But it's just
You might need to deal with the defamation cases.
Luckily, I work with a lawyer, so I have posted some fantastic art that I've seen, and it's actually led to a couple of doctors asking me to help them buy art. I made some money. So they've come to me and said, can you help me fix the art? And I was something, yes, please. But that's just, just in terms of being in a hospital, it's nice and that's just on a human level. It's much deeper in terms of Michelle's work and working with patients and their experiences. But those are just two. As a patient and just as a human and someone who loves art, So if you see any bad art that you see, send it to me. I have a fantastic backlog of them. Yeah. It's
Well, on that note, thank you so much to our speakers for being so generous with your time and with your comments. Thank you to Michelle, because this is such an important issue, and I think it goes to the point. I always say that artists, I think unfairly, we always look at artists to provide us with answers and solutions, but I think what artists do best is actually provoke questions, and this body of work has definitely done that. So thank you to Michelle. Thank you all of you for joining us. So just before we give a round of applause for our speakers, I also want to mention a project that Michelle is doing, which is an extension of the exhibition, which is called a project called Nobody Knows. What we're asking is people have their own stories to, you can either record them in the room next door, or you can actually upload either a handwritten note or type it onto our website. Michelle, at the end of the exhibition, we will give those to Michelle. Michelle has recently been funded by Creative Victoria to create an artist book of not only the work, but a collection of essays, and then these handwritten notes will also go into that artist book. It'll be an edition of 100. And what I think is really lovely about that project is Each artist book will have blank pages, so whoever applies the artist book will then actually be able to circulate that amongst their own family and friends, because this is an issue that is really, really broad. So I do encourage you, whether you can leave a story today or get on our website, it would be really great. But please join me in thanking Laura. I said we could go on for another hour. It's been a wonderful conversation. Thank you for your time. Thank you very much for joining us. Thank you, Carmel.
Thanks, Vince. Thank you all. Thanks, Beverley.